There's a lot of data for bortezomib. There's a lot of data emerging now on carfilzomib, and there's data on
let's talk about that,
exacerbib.
because there are some abstracts about that at this meeting. Tell us what you've learned about using carfilzomib in the newly diagnosed patient at this meeting that's updated us.
Yeah, I mean, I think it's clear that from both Ola's series that he's published previously, as well as Andrzej Jakubowiak's series, both with and without transplant, that the KRD regimen is clearly very active. And I think certainly with less neurotoxicity than we see with bortezomib, and probably better efficacy, at least from what we can tell than what we know, at least with the oral exacerbib on the surface of things right now. There isn't really any head-to-head data helping us to understand what it looks like in apples-to-apples comparison, but it certainly looks very encouraging.
Now, the French had a abstract here where their experience with KRD Upfront was reported. Are you familiar with that one, Saad? Do you want to comment on that?
Sure, absolutely. I think in terms of efficacy with that, KRD induction, transplant, KRD consolidation, followed by Len maintenance strategy that the French have employed in the phase 2 study. The efficacy appears to be okay, but they appear to have a safety signal with some toxicities relevant to the cardiovascular events that we have observed with carfilzomib in the relapse space. We have to look at that data a little carefully and try to tease out why that's happening.
I've heard that, but I was looking at the abstract just before we came in this morning, and when you parse right through it, there were no deaths on the KRD arm. There were mostly thrombosis and hypertension.
I think there was just one cardiac event, and that was, if I remember correctly, in the post-transplant setting.
Nevertheless, this is something that we need to pay attention to, and there is a randomized phase 3 trial in the United States going on, is that right?
That's right, of KRD versus RBD, and I think it'll answer very much for us the efficacy question and probably more importantly the safety question.
Now, it's not been presented at this meeting, but we did see a press release that in one randomized trial where carfilzomib was compared to bortezomib with melphalan-prednisone, the Clarion, is it Clarion?
Clarion, yes.
At least the press release suggests that there was no advantage to using carfilzomib, as I recall. But we don't know much about that study yet, Paul.
Well, from what I understand from the investigators involved is that there's no evidence of clinical benefit one versus the other. Having said that, this is an elderly population, and obviously the carfilzomib dosing is at 27 milligrams per meter squared, and perhaps that partnership with alkylators in that setting may be more challenging. I do think it touches, though, and from talking to Dr. Philippe Moreau, who's one of the principal investigators, this issue of the vascular toxicity in the older population does appear to be real. And I think that hypertension you touched on, Keith, is real. I think the other thing that we've realized is this vascular toxicity could be endothelially based. And I would sort of switch it and say, well, let's look at strategies to minimize that, because if we can, perhaps we can preserve efficacy and at the same time, get around some of these toxicities.
And we'll probably come back to this question in our relapse section as well, where we have a lot of choices in what we choose. But I think it would be fair to summarize the carfilzomib story as it's clearly highly efficacious. We don't know yet if it's going to be any better than bortezomib, and we need the results of the trial, and we have to balance that neuropathy versus this vascular signal, and a little bit more evidence. Although I know many of my colleagues at this meeting are telling me they're already been employing this carfilzomib, lenalidomide, dexamethasone regimen even before trial results. But whether that's the right thing to do or not, time will tell. What about, we talked about 4-drug regimens. They're not really reality yet, but you mentioned daratumumab. Saad, what's your feeling? Where are we heading in newly diagnosed patients with upfront therapy?
I think with the PI IMiD-based induction combination therapies, we are getting a significant number of patients to good depth of response, but not everyone. So adding an agent that improves the efficacy without adding toxicities would be ideal, and monoclonal antibodies may be the way to go there. So I think we're going to see more data with different combinations of data with triplets. The other advantage is that there's a population of transplant ineligible folks who are older, the patient population that we were referring to earlier. We mentioned that toxicity with K may be a concern for the more frail elderly patients. That patient population may also benefit from getting a drug which is efficacious without causing side effects. So monoclonals may be helpful.
Go ahead.
And if I
Paul.
may, Keith, sorry, I'd echo it because Amrita touched on it earlier. We're all participating in studies of RVD plus elotuzumab, RVD plus daratumumab, and now, of course, there are carfilzomib-based platforms with the antibodies coming forward. And I think that truly is the wave of the future. We're looking probably at our CHOP Rituxan equivalents in our disease now, certainly under study, and arguably, and I certainly know of community colleagues in the high-risk setting who've felt comfortable trying to use that upfront off protocol. I think we need to wait for more data, but I think at the same time, there's such impressive evidence from the antibodies that it does seem reasonable to me to be moving them up front as soon as we reasonably can.
I think that's probably where we're heading as trials emerge. Let's talk about